you. So, before I start, I'd like to say a few things. First, I was talking to some people now during the break, and I'm so happy to see that people came from very different places, young people, more experienced people, people that are more involved with research, people that are more involved with service provision. And this was exactly the aim of this symposium, to use our Latin American hub as a way to bring people together and start networking and discussing these important issues. Second thing that I'd like to say is that I'm a very lucky person to have been able to work with my previous colleagues. Is going to talk after me, and all the team that integrates Latin America. It's really an amazing experience. So, for my talk, I'll try to be not too long, because Ricardo and I have already discussed the key issues that are at stake here. So I'm going to maybe use Brazil and some of the work we're doing as examples of possibilities to try to integrate mental health into general health care. Jaime has just brought very fresh bread for you, published this week. From the last, this is 2008, just to show that it was from that moment that I think that the picture in the public health area started to change when the public health people and policy makers started to realize the relevance. I won't go to that. This is also to show that the burden of disease due to mental health problems not only is important in the rich countries, but also in the low and middle income countries. So I think this is another key issue to have in mind. And the results are not, as Ricardo has shown so well. Now, these are the ways, and I think that Ricardo also has tackled this. So one option is to, and we always need to push into increase funding and resources. We also need to increase training and have more specialists. For example, even in São Paulo, which is the area of Brazil, the richest area with more opportunities for training young people in mental health, the number of places available per year is very small. So if we go to other regions of Brazil and to other regions of Latin America, going into different countries, there are no opportunities for young people to train in specialized care. And then there is task shifting, and we've been discussing this this morning, and I'll continue to talk about that. Now, I will use the example of what has happened in Brazil, but it's applicable to several other countries of the region, Latin American region, and also other regions of the world. We've been through what's been called the psychiatric reform for at least 2 decades, and that has brought very important changes in psychiatric people in Brazil. For example, we moved from the care centered in psychiatric hospitals to care centered in the psychosocial care centers. some specialized services. Offer of beds, psychiatric beds, in general hospitals, residence, and rehabilitation programs. So this has been a huge change in the structure of psychiatric care in this country. But it was targeted to a very specific group of people with mental health problems, those who suffer from severe mental disorders. So I believe that the psychiatric reform hasn't as yet been successful in tackling the problem of common mental disorders. These mental disorders that affect a huge number of people, and particularly the people that have other health problems, as Harry has brought to your attention. The other thing is thinking about what has happened in terms of change in our primary healthcare system. This has been really a very marked and important change that has been following the principles and the movement that we can see all over the world. So the change that we saw in the organization and provision of primary health care in Brazil is also taking place in many different countries, not only in Latin America, but also in Africa and in Asia particularly. So now, in the last 15 years or so, the structure of the primary health care system in Brazil has been very much based on what's being called the family health strategy. And this new structure of primary care, I believe it has been shown a great potential to integrate mental health care into general health care for several reasons. The first one is that this primary health care structure delivers longitudinal care. They are supposed to follow the community, people who live in that community along their lives, from birth to, from conception to death. So it's longitudinal care. This is a very important characteristic. Second is that it's the gate to have access to the whole healthcare system. Care is coordinated. There is a team that is responsible for care, and the care is coordinated. Care is integral. Is that right? Is that kind of in English? I wasn't sure about that.
Comprehensive care.
Comprehensive. Okay, thank you. Very kind professor of primary care here at the Department of Preventive Medicine. And last but not least, the population coverage that we've reached recently is huge. It's huge. We're talking about more than 5,000 municipalities with at least some form of care through the family health strategy, and more than 100 million people. I always say, well, this is huge. So the potential for the system is really impressive. We can see how fast the number of people covered by the family health system in Brazil increased over the recent years, last decade mainly. And we can see here that most of the country is also covered by the family health care system. So this gives us an excellent opportunity to work on what are the possible options and ways to integrate mental health care into the structure of primary care. Second thing, the other thing I'd like to stress, and Jaime has already pointed that out, we're talking about cities, people living in cities. It's interesting how when we go to the rich countries, when we meet sponsors, not the children, but most of the sponsors, NGOs, they think that the key thing is to give access to people who live in remote areas, which is true. I mean, they need to have access to care as well. But more and more in our countries, people are living in cities, in large urban centers. And this is the challenge. I think this is one of the main challenges that we have. How, although they are all packed here, and they are packed here, and they are packed here, how do we allow these people to have access to proper and effective care? I think this is something that changes or shifts some of the previous way that people are used to think about primary care. Well, most of you know, but some don't. The structure of this family health system in Brazil, this is a typical clinic. And this is the team. And again, Jaime mentioned that, and Ricardo said about the Pakistanis ladies. Well, we've just finished a survey with some 3,000 people, Andrea is sitting there, led this work, and we finished this survey with 3,000 people who work with these family health care teams, and we have found that there are 9 women for each man working in the primary care system in São Paulo. So it's not that different from rural parts, the women there. And there is a doctor here. There's a doctor.
Long time ago.
And, okay, so there have been several approaches to integrating mental health care into primary care here in Brazil. Some are official, so there is this program. I have a colleague here, Karen, who's been working with that for a long time. They're called masks, which are teams of people who have specialized skills, who help the teams from the family health system to deal with people with mental health problems. This has been one strategy. This is another example, a very well conducted study by a group of colleagues from different universities who developed a package of training for the medical doctors and nurses of the family health teams in order to enable them to better detect and therefore treat people with mental health problems. So they developed this multifaceted program with a reasonably long duration, 96 hours. It's a very intensive program. They use it as the basis. The manual for mental health care developed by the WHO. And they then trained these teams in 4 large cities in Brazil, and they measured recognition rates before and after the training. And 6 to 8 months after the training, results were really very disappointing. They didn't observe changes in the rate of recognition. More than that, nurses significantly improved their rates from 23 to 39%. So doctors decreased from 42 to 30%. So maybe that's not a very effective way I think that there are other issues, and they've been discussing this. But we have chosen a different route in terms of task shifting, because this is task shifting. We're shifting the ability to primary care people instead of specialized people. So there are some examples. Ricardo already gave you examples, and Haim mentioned. Postpartum depression is a very important problem, and the good thing about it is that pregnant women in these settings, they are seen by the health service. They go there to receive care. So it's a good opportunity to also try to detect and do something, because the prevalence is so high, and also the persistence is very high. Along lots of examples, Faisal that's sitting there followed almost 800 women from antenatal care to 6 months post-delivery, and 50% of those who were presenting depressive symptoms during pregnancy were still presenting depressive symptoms 6 months after delivery. So it's a very important problem. And this is only an example that not only Ricardo has also mentioned that, but not only low and middle income countries are trying to do this task shifting strategies, but this is a study that was run in Britain not a long time ago. And the results were really promising. These trained health visitors who saw women in the postnatal period were able to help them to reduce depressive symptoms using a kind of psychologically informed approach. And this is the work that I think Ricardo mentioned is one of the keystones in this area. The study that he led in Chile, in the primary care centers in Chile with women with postnatal depression. And nurses were responsible to deliver the care, step-in care, which is something also very interesting, because they are trained to be able to identify when each one needs more complex care, as according to the severity or to the evolution of their symptoms. So, in this scenario that we thought we should try something here as well, and we then proposed this study called ProGravida. This is official name for this study. This study was coordinated by myself and by Professor Marcus Kazuki, who's at the back there, with strong input from Ricardo. At the time he was based at the University of Bristol. And one of the interesting things in this study is our partnership with one of the social organizations responsible for providing care, primary health care in São Paulo, Associação de Saúde da Família. There are other people that have been involved in the program in this room as well. I mentioned Karen that's there. Simone was already working with others. So Andrea also was involved at some point. Anyway. So what we did? We wanted to evaluate simple, what we call simple low-cost intervention delivered by auxiliary nurses. And this is important. Why auxiliary nurses? The family health teams are composed here by a doctor, a graduate nurse, 2 auxiliary nurses, and 5 to 10 community health workers. And we through formative work, we identified that the auxiliary nurses were in the best position to have this kind of role. Doctors and nurses were too busy, as were community care workers, and we thought that they would be the right people to be trained to shift the task into their hands. We ran then a study, finished fieldwork last year, which is called Pragmatic Community Trial with 12 family house strategy clinics involving almost 80 teams. Half were drawn to be trained and supervised to deliver the intervention, and half of these units, 6 units, were used as controls. So they just did usual care to the women with depressive symptoms. The intervention here, and I think this addresses one of your questions, is that we got a little aspect of the CBT, which is quite simple. That's called problem solving. Because we thought, well, it's well structured enough, and it's very likely that the auxiliary nurse will be able to deliver that kind of approach if they are supervised for that, if they're briefly trained and supervised. Also, we trained them into a stepped care approach. So there were clear rules for example, when to put to the team that this woman might be in need of antidepressants, for example. Or if anything worked, they might call the psychiatrist from the support team to give some advice. And the primary outcome of this study, they delivered 6 sessions at home, so they would combine with these women, they would see them at home. We thought that would be the best setting to deliver it. But sometimes if the woman didn't want to have it at home for several reasons, gender violence being one of those, they could have it in the clinic. And we assessed the presence of depressive symptoms 3 months after beginning the intervention. And this is what we got. We had more than 300 people in each area. And results, although we managed to have a difference, an 11% reduction in the prevalence of depressive symptoms 3 months after the intervention. We were not very impressed by the size of the effect, unfortunately, so we need to go through that to see whether it's possible to improve it or not. But at least, I think it shows that this strategy may be a path to follow. And just to close my, I'll talk a little bit about what we're doing now. This has been shown already. We're developing and testing. So we're going a step further in this task shifting approach, incorporating the technological aspect as an extra step on the task shifting. And we're working now with people with chronic conditions as well. Again, we are proposing and we're testing that those who will be responsible for following delivering this intervention are the auxiliary nurses. And one distinct thing is that we have two completely different settings, because the study is being run in São Paulo with the family health strategy, but it's also being run in Lima, where there is a completely different healthcare structure. And in Lima, we're working much more on what we can call secondary care, clinics specialized to see people with hypertension and diabetes than primary care. So this is something very interesting, because we're testing whether the principle of this intervention can be applied to different settings and different situations and be as effective in both. We've done a first phase that we call formative research. We developed and tested the system, which I'll show you a bit more in a minute. And we've applied it already to 20 patients in São Paulo and 15 patients in Lima. And results from this pilot are promising, and they are guiding us to prepare the effectiveness research, which will be a very large trial involving some 800 people in São Paulo and 400 people in Lima. And the difference of sample size has mainly to do with the method for randomization. In São Paulo, it's a cluster randomized trial. In Lima, it will be an individually randomized trial, so the sample size can be smaller. But the power is very similar. And after that, we'll start the third phase, which will be dissemination and implementation. So I said it's a system. And it's a system because it involves an app. The development was led by Marta and Maria, who is now the project manager in Northwestern. So the app called Codimo can be downloaded to a smartphone with Android at the moment. And it has a sequence of sessions that will be delivered on an automated basis. So we programmed 18 sessions of behavior activation. This time we are not using problem solving, because through the app we thought, well, maybe behavior activation is much better fitted to be delivered this way. So the app is programmed to call the patient to do a session from time to time, 3 times a week during 6 weeks. And there are ways to also send some messages to the auxiliary nurse, who is on the other side of the system, because the app communicates to a server, and the nurse can have access to this web-based interface that shows how patients are doing in terms of the use of the app and sessions. There is no information about severity of symptoms or any clinical information. This was something that we discussed a lot. We decided for this, it's better not to involve the nurse with something that will be more complex. So they can see here what the patients are doing their tasks. And if they lose 2 in a row, this red spot will come up, and the nurse knows, oh, this guy is not being adherent to it. If it's a yellow, he lost one session, so keep an eye on him. Well, there are lots of details that I'm not going to here, but I think that this gives you an idea that the nurse works with a tablet at the clinic, just to, and she will get into contact with patients from time to time to help improve adherence to treatment. So this is what we're testing right now. So, to conclude, if these interventions shown to be effective, then we go to the next stage, which is structuring training modules to disseminate and incorporate in the health systems. If they're not, we need to identify the reasons, we need to search for new models that can be tested. I think that with this, I'll conclude, I'm open to a few questions if you have. Thank you.